Hey there, everybody, and welcome to this presentation on documentation. I am your host, Dr. Elise Snipes. In this presentation, we're going to review basic components to ensure a complete client file, a thorough assessment, treatment planning, and discharge documentation. Let's start out with the basics, administrative and intake forms. These are your forms that don't have any specific clinical information. They include your demographics, the responsibilities of the client and the clinic, and insurance and financial agreements. Administrative and intake forms can often be done by a administrative assistant or a behavioral health tech with the client. Your demographic information form is generally held by the office, whoever does your billing, for administrative reasons. It's kept separate from the medical record and is used for administrative and billing issues, quick reference in an emergency, and is required by most accrediting agencies. You need to have the person's name, address, emergency contact information, telephone number, and preferably information about their current primary care physician, etc. The notice of appointment form, pretty self-explanatory, reminds the client of upcoming appointments, instructs the client on what to bring, and tells the client about what to expect. Obviously, this is more for the first appointment to make sure that the client knows they should bring all their medications and what they should expect in the session. Future appointments, you're often going to give them, when they're leaving, an appointment card, which is their notice of appointment. Your consent to treatment forms are so important. These are required by most accrediting agencies as well as by many states in state law. It's also an ethical requirement. We need to make sure we are providing informed consent. The consent for treatment form is a written acknowledgement that the person actually has received informed consent, which means they are aware of various situations in which they can be discharged. For example, if they are non-compliant with treatment or whatever reasons your organization has set forth. The limits of confidentiality, the cost of services and who's responsible for paying, privacy practices, and the various options for treatment and the associated benefits and risks. It's important that we make sure that we present the benefits and risks of the treatment that we're offering, let them know that there are options out there, as well as discuss the issues related with non-treatment. The initial client information form is completed at the first contact and includes basic demographic and insurance information. This allows the administrative staff to check coverage limits, deductible and copayments, policy limits, prior authorization requirements, and the types of providers that are covered for services. For example, some insurance companies may cover LCSWs, but not addictions counselors. So it's really important that you are aware of the types of things that insurance companies look for when deciding whether they are going to reimburse a claim. The financial policy or contract indicates that the client is ultimately responsible for payment. The clinic cannot guarantee insurance benefits because we can't guarantee that the insurance company is actually going to agree to pay. If there are any upfront payments required by the patient, and this includes copays and deductibles, in most cases, it is illegal to waive copays and deductibles. You need to collect these. The client, when they signed their agreement with the insurance company, said, okay, I agree to pay my share of the bill. And that is an agreement between the client and the insurance company. When you became a provider, when you got on the panel for the insurance company, you agreed to follow the guidelines set forth in the policies, which includes collecting copays and deductibles. There should be a policy regarding payment for the treatment of minors. Policy regarding payment for charges not covered by insurance. For example, maybe insurance covers counseling, but they don't cover drug testing. So who's responsible for that? We don't want any surprises to pop up on the client's bill because that often causes them additional stress. They may feel taken advantage of, and it can lead to lawsuits. There should be policies stated very clearly about non-payment and late payment issues, acceptable methods of payment, policies regarding missed appointments and outside consultations. For example, if the client wants you to consult with their primary care physician or consult with their lawyer, there need to be policies for how that would be billed, because obviously those are probably not going to be covered under insurance, and what you are willing and not willing to do and the process for that. For example, if you're going to consult with their attorney, you will also need a release of information. There should be a policy that enables the agency to collect payment via a collection agency as needed, and it should clearly indicate when payments are due, and generally this is at the time of service. Some organizations will also have a policy for assignment of benefits. This can get a little bit tricky. Consult your attorney if you are looking to have assignment of benefits. This is more applicable if you are an out-of-network provider. Waiting room postings are required by most accrediting agencies, and some states also have this in their laws and regulations for patient rights. What you need to have in most waiting rooms posted conspicuously include a statement of client rights, the number and contact information for the client ombudsman, a grievance policy, the mission statement, a code of ethics, the facility's license or licenses, and evacuation routes. If you think about any doctor's office that you've been in, you will recognize that most, if not all of these things, you've probably noticed before. A therapist ethics statement needs to be completed. Now, it doesn't have to be in every chart, but it is important to have at least in the personnel file of every therapist that they have acknowledged that they are aware of and willing to comply with the ethics of their profession. They understand Hipaa privacy policies. They understand state and federal confidentiality regulations and state and federal laws regarding child and elder abuse reporting. It is helpful to have documentation of training, not just somebody saying, yes, I agree to all these things, because that doesn't necessarily mean that they know what they're talking about. We do want to be able to demonstrate that the clinicians have had training and are aware of all of these policies and can implement them. If you work with minors, there needs to be an agreement that parents will respect certain rules of privacy regarding what their children disclose in therapy. There needs to be a clear discussion with the caregivers or the legal guardians of any minors about the limits of and the minor about the limits of confidentiality, as well as how you're going to handle what is said in session and how you're going to handle payment for services. Hipaa is a big thing, and you've probably heard about it, you've probably studied it, but we're going to go over it anyway. Hipaa stands for the Health Insurance Portability and Accountability Act. The Hipaa Privacy Rule refers to standards of disclosure of protected health information, or PHI, by covered entities. You must, can't emphasize this enough, have written contracts with every business associate to safeguard protected health information. If a business associate, for example, your online behavioral health, your electronic medical record, if they say, oh yeah, we're Hipaa compliant, don't worry about it, that is not acceptable. You have to have in your possession a written contract with every business associate agreement, or with every business associate. Covered entities, which include you, may disclose protected health information without the individual's consent in the following situations: sending information about the patient to the patient, information used in the normal operation of providing services, consultation, and referral, payment operations and billing services, healthcare operations such as quality improvement, case management, utilization management, audits, business development, and administrative activities may use unlimited data sets in which records are de-identified. So if you're doing some of these things, you may have to de-identify some of the records. It's important to be aware, and that's covered in other Hipaa classes. But it is important to be aware in which cases you can use information, but it has to be de-identified. Without the individual's consent, you may also disclose their protected health information when their health, welfare, or safety of the person or others may be in jeopardy. And in the event the provider is served with an appropriate court order signed by a judge, and that is the crucial part of this. The court order must be signed by a judge in order to release protected health information. It's also important to remember that we want to release the minimum amount of information necessary. You don't want to just hand over the whole file, and you definitely don't want to hand over the whole file plus the progress notes. You need a separate court order for progress notes release. Written authorization from the individual preceding the release of PHI will allow you to release PHI for a disclosed period of time. These disclosures, the release of information forms, may not be combined with any other documents. They must be specific and written in plain language, not all that legalese crap. Dated with the beginning and ending date for release. So the client may say this is good for 2 weeks or 1 year, but you need to have a beginning and ending date. There needs to be a description of the information to be disclosed, the name or description of the person or entities authorized to make the disclosure, as well as a name or description of the person or entity to whom the disclosure is made. So I would need to have my name and address on the file as the person authorized to make the disclosure, and I would need to have, for example, the name of the probation officer and the address if I am releasing information to them. The purpose of the disclosure, the patient or legal guardian's signature, the individual's right to revoke authorization statement needs to be there. There also needs to be a statement about the provider's ability to condition treatment on the authorization. In some cases, for example, when I worked for the Department of Criminal Justice, when I would work with clients who were mandated to treatment by the courts, and the courts were paying for treatment, they were basically required to sign a release of information to have information given to the court and to their probation officer. If they didn't, the court wouldn't pay, and therefore, if they wanted services, they would have to figure out how to pay for the services themselves. So there were some little hiccups there, but we needed to be able to articulate to them that, hey, if you don't sign this release of information, then the court will not pay for your services. And, if you need treatment, you'll have to find another way to pay for services. And the disclosure also needs to include the potential for redisclosure and any subsequent loss of protections. And for more information about that, you can see 45 CFR 164.508C2. The notice of privacy practices. This is different than a release of information. A release of information allows us to, guess what? Release information. Privacy practices is a notice that's required by Hipaa, and it describes people's right to privacy, the limits of confidentiality, the duties of the covered entity with regard to protection of protected health information, and breach notification, the uses and disclosures of protected health information that are permitted or even required, such as abuse reporting, without patient authorization, the complaint process and a contact person should somebody believe that their privacy has been violated, the right to revoke authorization, the right to inspect or amend their protected health information if they think something in their chart is wrong, and the right for a full accounting of all disclosures, which is why every time you disclose a patient's protected health information, you need to keep it in a log somewhere. So if the client ever asks, who have you given my information to, you can provide a full accounting. Clients have the right to review their medical records. If in the individual's best interest, the clinic may choose not to disclose progress notes, information from legal proceedings, or lab results. And this is very tenuous. It's important to walk that fine line between transparency and client's best interest. When you write your notes, when you write your assessment information, keep the information as objective as possible. If you make a subjective statement, then you need to support it with as evidenced by. For example, client seems to have stalled in making progress and in treatment as evidenced by, and then support it with objective observations that can be used. You want to stay away from as much subjective language as possible. So And always assume that the client is going to read the information. Is it likely to happen? Often not, but clients, occasionally will. So it's always best to err on the side of assuming that the client will see what's being written. And we'll talk about other ways to address this issue later. Individuals have a right to amend information in their file that they believe is inaccurate or incomplete. If the organization, decide that the information is accurate and complete and refuses to amend the information, clients have the right to have their request for amendment included in their file. For example, if you're working with somebody who has a personality disorder and you have put things in their chart that they disagree with, but you believe are objectively and factually accurate and don't believe that they should be changed, then your stuff can stand. However, the client can request that their perception, their interpretation of what's going on is also included in their file. Releases of information. No protected client health information should be discussed with anyone without the written permission of the clients, except in areas as defined by the Hipaa regulations. We already talked about that. Clients have a right to know how the information will be used and which files will be released. Releases are typically valid for 1 year unless otherwise specified. It's still important to have that beginning and ending date, even if you assume it's good for a year. Hipaa indicates that progress notes are kept separately from other protected health information. A request for a client's entire file is not sufficient to obtain progress notes. A separate request for progress notes but must be included if someone wants the actual progress notes. In order to release information of a minor, the legal guardian of the minor must sign the release in most cases. Hipaa requires that agencies keep a record of each request for the client's medical records from within and outside of the agency. If you're working in a large agency, maybe with another department that has case management services, and they request information from your client's record, that goes into the accounting of disclosures as well. Clients have a right to request an accounting of who has requested their medical records, even if you didn't divulge the information, they do have an account, the right to know who is requested as well as who has been provided information from their medical records. Let's move on to assessment forms. The goal of the first session, the initial assessment, is to establish and document a diagnosis, identify functional impairments, and determine the respective onset, frequency, duration, intensities, and types of symptoms in the presenting impairments. So basically, we're looking at their symptoms. How bad is it? What triggers it? How frequent and how intense is it? The initial assessment determines the need for services. You want to make sure that all of your documentation is in behavioral terms. It's observable, it's measurable. So even if we're talking about depression, you want to try to elucidate what you mean by that. So the client reports being depressed as evidenced by. That phrase is your best friend in documentation, as evidenced by. The intake needs to describe baseline rates of behavior, such as, how frequently the person is crying, how many hours of sleep they're getting per day. Measurable. So you can look at baseline, you can look at when they come in, what are their symptoms like, what are the impairments like, and then when you do the reassessment, you can go back and look and see if things have started to improve in frequency, intensity, duration, or type. 5 sources of information. The Diagnostic Interview and Mental Status Exam provides observations from the clinician. It's subject to limitations of validity and reliability. We're not using something that has been tested and retested. So we have our own subjective interpretations of things. The diagnostic interview must clearly document the onset, frequency, antecedents, what precedes the problem, intensity and duration of each symptom. You can think of this or remember this with the acronym of AID. Onset, frequency, antecedents, intensity, and duration of symptoms. It's also helpful to use standardized objective testing measures that are valid and appropriate for the person being assessed. For example, the Beck Depression Inventory. Or for the DSM-5, there have been a lot of screening and assessment instruments if you go to the DSM-5 website. Self-report questionnaires, historical documents such as prior clinical records, and any collateral information you can get from significant others, from employers, from criminal history, whatever it is in the setting that you're working in. The psychological evaluation is a part of the initial assessment. It's a structured interview designed to provide symptoms, history, awareness of daily activities of the person, awareness of their ability to relate to others, substance abuse issues, and an extensive mental status examination. To complete a psychological evaluation requires a professional with a thorough knowledge of developmental and neuropsychological issues, because you're going to be looking not only for mood disorders, but also personality disorder issues, neurocognitive issues, and potential medical issues that could be presenting as psychological syndromes. When we talk about assessment, one of the things that people have some of the most difficulty remembering are the diagnostic criteria for personality disorders. So I included in here the mnemonics for personality disorders. Your cluster A personality disorders, you have paranoid personality. The mnemonic is suspect. Spouse infidelity is suspected. Unforgiving, they bear grudges. They're suspicious of others. They perceive attacks and react quickly. They tend to be very hypervigilant. Enemy or friend. They tend to suspect other people of wanting to do them harm all the time. Confiding in others is feared. They are afraid to trust anybody. And threats are perceived in benign events. When we think of paranoid personality, none of these is all that surprising. Schizoid personality is characterized by the mnemonic distant. They tend to have a detached or flattened affect. They're indifferent to criticism and praise. Sexual experiences are of little interest. Tasks are often done solitarily. There is an absence of close friends. They neither desire nor enjoy close relationships, and they take pleasure in very few activities. Schizotypal is different than schizoid, obviously, and it is characterized by the mnemonic me peculiar. Magical thinking or odd beliefs, and experiencing unusual perceptions. This is one of the things that sort of starts to set it apart, because other personality disorders do not have the magical thinking and the unusual perceptions. Paranoid ideation, eccentric behavior, constricted or inappropriate affect, unusual thinking and speech, lacking in close friends, ideas of reference, anxiety in social situations, and then R stands for ruling out psychotic disorders and pervasive developmental disorders. We do want to rule out things like schizophrenia that may also produce magical thinking and unusual perceptions. Cluster B paranoid personality disorders. Antisocial is characterized by the mnemonic corrupt. Conformity to law is lacking. Obligations are ignored. There's reckless disregard for the safety of self or others. Remorse is lacking. They tend to be underhanded, deceitful, lying. Planning is insufficient, and they tend to have a temper. Borderline personality disorder is characterized by suicide, abandonment fears, mood instability, suicidal or self-mutilating behavior, unstable and intense relationships, impulsivity, control of anger is difficult, identity disturbances, dissociative or paranoid symptoms that are stress-related, and emptiness that tends to be pretty chronic. Now remember, there are other videos that go through each one of these characteristics and describes them in much more detail. I just want you to remember that we need to, when we're doing our evaluations, we need to rule out or rule in comorbid personality disorders. Histrionic personality is characterized by praise me, provocative or sexually seductive behavior, relationships considered more intimate than they are, attention is demanded, influenced easily, style of speech tends to be impressionistic and lacking in detail, emotions are rapidly shifting and shallow, made up physical appearance to draw attention to self, and exaggerated or theatrical emotions. Narcissistic personality is characterized by the mnemonic special. They believe they're special. They tend to be preoccupied with fantasies of unlimited success, power, or ideal love. They experience a sense of entitlement. They can be conceited, engage in interpersonal exploitation. They're arrogant and lack empathy. And the final cluster are your cluster C, or your anxious, fearful group. Avoidant personality is characterized by cringes. Certainty of being liked is required before being willing to get involved with others. Rejection preoccupies their thoughts in social situations. Intimate relationships are restrained due to fear of being shamed. New interpersonal relationships are rarely created. They get around occupational activity that involves significant interpersonal contact. They're embarrassed, or potential for embarrassment prevents them from trying new activities or taking personal risks. And the self is viewed as unappealing, inept, or inferior. Dependent personality disorder is characterized by reliance. Reassurance is required for decisions. Expressing disagreement is difficult. Life responsibilities need to be assumed by others. Initiating projects is difficult due to lack of self-confidence. Alone, the person feels helpless and discomfort when they're alone. Nurturance, they go to excessive lengths to obtain nurturance and support. Companionship is urgently sought when any relationship ends. And they have exaggerated fears of being abandoned. And finally, obsessive compulsive personality is characterized by law firms. They lose the point of activities due to preoccupation with detail. Their ability to complete tasks is compromised by perfectionism. They have an attachment to worthless objects. Friendships are excluded due to a preoccupation with work. They tend to be inflexible, scrupulous, or overconscientious, reluctant to delegate, miserly, and stubborn and rigid. In addition to looking for mood and cognitive symptoms and personality disorder symptoms, there are also abnormal signs and symptoms that you want to look for. And this includes abuse and neglect signs and any medical issues that could be contributing to their presenting complaints. You also want to look for suicidal and homicidal ideation, plans, and history. Remember, risk factors for suicide include prior suicidal behaviors, social isolation, current stressors, recent history of major depression or bipolar disorder symptoms, or traumatic brain injury. The Diagnostic Assessment, sometimes called the Clinical Formulation or Integrated Summary, summarizes the intake and assessment material and presents problems as evidenced by frequency, duration, and intensity, identifies in general the history of the person and what led up to the current situation, identifies current functional impairments, mental status, and diagnosis. It provides information for treatment planning, identifying what will be done to address the symptoms and to what end. Why exactly are we doing this? Why is the person going to group therapy? Why is the person going to see a psychiatrist? And it provides information to third-party payers supporting the diagnosis and treatment approaches. Treatment planning begins with assessment. It's so important to remember this, and most insurance companies require that. Individualized treatment plans develop a working relationship with the individual. Treatment planning is usually done in the initial meeting with the therapist and should be written in the words of the client. Make sure to avoid writing a plan that is overly precise or overly vague. And I know you may be thinking overly precise, but yeah, you can get too much down in the weeds. You can be too overly precise where you may actually set the person up for failure. So keep your treatment plan objectives and goals as objective as possible and use what they call the KSA format. Knowledge. What knowledge does the person need about the disorder, about the presenting issues? What knowledge does the person need about how they are experiencing the disorder or the presenting issues? What skills does the person need to develop? And how can they translate those skills into abilities? The format of the treatment plan corresponds to the assessment material and identifies specific measurable outcomes. It requires 3 basic types of information: the main problem or symptom. So the patient presents as depressed, as evidenced by, and the main goal. What will it look like, for example, when the main problem is gone? So the patient presents as depressed, as evidenced by, blah, blah, and the client wishes to be happy, as evidenced by. Steps to achieving the goal. So how are we going to get there? We know where they're at right now, what their presenting issues are now, and where they want to go. So what are the steps that they need to take to get to that ultimate goal? And what are the treatment strategies that are going to assist the person in taking those steps? When writing treatment plans, don't make it too difficult. Just keep asking yourself, what is the next thing I need to do or the patient needs to do to get from point A to point B? Well-formed treatment goals can conform to the mnemonic, I'm smart. I, important to the client. M, motivational. The goals are not too easy where they're just not, excited to try it, but they're also not too hard, so they're not overwhelming. They're specific, small, concrete, and behavioral. We want to make sure that the person knows exactly what they're doing. They're measurable. They focus on the presence of or developing something. What is the person going to do? They're going to learn about depression by reading chapter 3 in the book provided by their therapist. It's achievable. It's something that they can actually do in the identified time period. And they're relevant. It progresses in an incremental fashion. Every single step in that process in the treatment plan, the person needs to be able to look at that step and say, I see how this is important to accomplish to help me achieve my ultimate goals. Low levels of motivation lead to low performance because there's little effort and low reinforcement, or there's a perceived threat. High levels of motivation lead to high levels of anxiety and low performance. We don't want people to be overly motivated where they think they have to have this, because then if they don't get it, it feels catastrophic. We want to help them increase their motivation so they're excited, but they are not overwhelmed. Reassessments need to be completed quarterly for outpatient therapists, monthly for people in intensive outpatient or partial hospitalization, and typically weekly for patients in inpatient. Reassessments should be completed with the client and signed by the client, and evaluate the course of therapy based on the most recent data. They include a cumulative assessment of therapy in general. What have we done this week, this month, this quarter? An assessment of the sessions. How well are we working together? Identification of client cooperation, insight, and motivation as evidenced by. Client progress and setbacks as evidenced by. Areas needing more work as evidenced by. Treatment strategies that are working, and necessary modifications and what those modifications are going to be. Progress notes need to be completed after every contact with the client. They objectively document the course of therapy and clearly reflect the implementation of the treatment plan, regular assessment of the client, and treatment effectiveness. When you write your progress notes, you need to refer back to the treatment plan goals, not just we did this, that, and the other thing, but we talked about XYZ as it relates to treatment plan problem 1. An outside reader should be able to understand what's going on and why you are focusing on what you're focusing on in session. They may be written in session to save time and improve patient self-efficacy, and I'll describe how to do that in a minute. They must be clear and timely, that is, write them when you do them or that same day as a protection against liability. A lot of agencies will use the terms DAP or SOAP notes. DAP stands for Data Assessment and Plans, and SOAP stands for Subjective, Objective, Assessment, and Plans. Now remember earlier I said we want to steer away from subjective as much as possible. But if you must put in something that's subjective, like the patient is doing well, that's very subjective. You want to add the phrase as evidenced by. The patient is doing well as evidenced by. So you're getting the subjective and objective in there together. The data that you're looking for includes what specifically took place in the session. What did you discuss? What did you do? Therapeutic interventions, clinical observations, all that as evidenced by stuff, test results, homework assignments received and assigned, diagnosis, a brief mental status exam. This needs to be completed on every patient at every contact. And when I worked in residential, when I was a supervisor, I insisted that it also be done in every group. Again, we'll talk about how to do that in a minute. Current stressors, impairments, and affective and cognitive concerns, and current behavioral concerns. Progress notes worksheet. Now, this is a great way that you can involve the client, empower the client to feel like they are really in control of their therapy, that they are having a say, that they are in partnership with you. Preprint on the form, the date, the time, the therapist, i.e. you, and the patient's treatment plan goals. Ideally, you only have like 3 goals. The patient will put their name on the sheet. And then you have these other questions. I feel blank today because. That helps us understand where the client is emotionally. The symptoms that are bothering me the most are the 3 best things that happened this week, the worst thing that happened this week, and I dealt with it by, new issues, if any, that have come up this week, treatment plan goals, homework, progress, challenges, and needs is the next section. So you'd put treatment plan problem 1, address depression, for example. To address this issue over the past week, client would fill that in. I feel my progress is, good, average, excellent, because challenges to my progress are to continue to make progress. I need. This helps us, helps the client identify what they need, what kind of supports, resources, tools they may need to continue to make progress. In session, we discussed, and my goals for the upcoming week are. This is great to have the client complete as much as they can before session starts, while they're in the waiting room. And then the last 10 minutes of session, they complete the final part of it. And then you as the therapist can go in and add your notes at the end. But this gives the client, encourages the client to really paraphrase and identify what's going on and see the progress that they've made. I also give my clients a copy of their progress notes worksheet to take home with them so they can remember the progress that they've made and what they're supposed to be working on. Common errors in progress notes, errors of omission, things you forgot to put down, like the date, the stated objectives for the session, the signature of the therapist, or no starting or ending time. Errors of commission are errors that happen because information that is provided is either inaccurate or incomplete. Don't provide information that is vague and doesn't validate any diagnosis, impairments, or demonstrate any therapeutic interventions. Don't talk just to talk. Make sure you're putting down information, you're relating it back to the treatment plan, which is tied into the assessment. Group therapy progress notes. You can start out your group therapy progress note with a general symptom checklist at the top. Maybe you're doing a group on depression, for example, so you can have general depression symptoms so they can check the symptoms they're currently experiencing. And then again, have the date, time, topic, and therapist pre-printed on the form, and then have the client fill out the following sections: their name, I feel blank today, the best thing that happened today, the worst thing that happened today, and I dealt with it by, new issues, if any, that have come up since last session. On a scale of 1 to 4, I feel my treatment is progressing not at all, that's a 1, 2, slowly, 3, as expected, or 4, well. What modifications might be helpful? And one useful tool or perspective I got out of group today was, and this tool or perspective will help me because. Other forms that can be used. Safety contracts. Now, it's important to remember that research over the past 10 years has identified that these are not worth a lot. They are not to be relied on as an intervention. They are not a legal document. However, you can create them at admission, and it helps represent the client's commitment to responsible actions. It identifies resources the client will use in the event of a crisis, including telephone numbers of emergency contacts, 911. Identifies potential triggers and warning signs for crisis. So we're encouraging the client to think about things ahead of time. Identifies best and worst intervention strategies when in crisis. That way, people who are attending to the person know what is most helpful and what is least helpful. It must be signed and dated. And it also provides a means to contact the therapist or an emergency contact in times of crisis. Remember, this is not generally something that pops into somebody's mind when they are in extreme crisis. So this is a brainstorming procedure that you go through at admission to identify, in the event you are in crisis, how can I best help you? In the event that things start to get stressful, what symptoms, what triggers, what warning signs do you notice that tell you, hey, things are fixing to go south really fast and I need to take action? The discharge summary and termination letter must be provided even for clients who drop out, most especially for clients who drop out. A client is not officially discharged until a termination letter is sent. So send the original, keep a copy in the record. They're designed to reduce the clinic from responsibility for the client's actions. It doesn't absolve you of anything, but it does help show that you didn't abandon the client, that you provided referrals, and that you tried to, help address any issues that were going on. It provides a transition point to the client, ensures they're not abandoned, and summarizes the effects of therapy. This is true even if the client discharges against medical advice. You want to identify what the assessment said, the interventions that you tried, the effect that it had, and your referrals to the client for continuing care. The discharge summary should have the initial and final diagnosis, a functional assessment, how they're doing at discharge, the client's risk of relapse, the date or dates of service, your summary, general summary of progress and reasons for termination. The Clinician's Thesaurus, the Guide to Conducting Interviews and Writing Psychological Reports by Edward L. Zuckerman, is a really helpful tool to have when you are learning how to do documentation. Beginning and ending the interview can be a little bit challenging for people.